Okay, back again with my third and final installment for this presentation. But okay, so the first assessment tool I'm going to talk about is the Yale Brown Obsessive Compulsive Scale. This is a clinician rated instrument. So if you're assessing somebody with OCD, this is something that you administer and rate. So, blah, 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 lost my train of thought again. Um, This is kind of like the gold standard of um, assessment instruments for OCD. It is a semi-structured interview, technically, that assesses the presence and severity of obsessions and compulsions over the past week. So that's an important specification there. It takes roughly 30 minutes to administer. It is comprised of a symptom checklist as well as a severity scale. So it's assessing for the presence of specific symptoms, but it's also looking at how severe these symptoms are, which is an important factor in kind of case conceptualization here. So the severity scale includes 10 items, 5 for obsessions, 5 for compulsions, and each item is rated by the clinician on a 5-point scale ranging from 0 to 4. So 0 indicating that there are no symptoms, and 4 indicating that there are incredibly severe symptoms. So assessors rate the time occupied by the obsessions and the compulsions, the degree of interference with functioning, the level of distress, um, like how much are they attempting to resist the symptoms, and the level of control that the individual demonstrates over these symptoms. So it has pretty adequate inter-rater agreement and internal consistency and validity. It is most commonly used as a treatment, as a measure of treatment outcomes in psychotherapy and like CBT treatment studies. Or like just in clinical practice. So some criticisms of this scale. So there is some evidence that suggests that the Yale Brown Obsessive Compulsive Scale has low discriminant validity with depression because it exhibits moderate to strong correlations with depression severity. But also there's a possibility that there are, so like in terms of the factors, the YBOCS only has 2, and some of the studies I've read said that there are possibly like as many as 5. So the Yale Brown Obsessive Compulsive Scale, second edition, was developed to kind of rectify some of the problems with the original scale, and it has like a different factor structure. It incorporates some of like the phenomenological advances in like how we understand OCD, and its like ultimate goal is to differentiate from depression like more effectively than the original scale does. But like despite these improvements, um, there's still like mixed support for it, and it's like the factor thing. Um, the original scale is more popular in use, like from what I've read. Then there are some self-report measures that are used. There's the Florida Obsessive Compulsive Inventory. This is a 20-item symptom checklist that includes 10 common obsessions and compulsions. These are derived from the YBOCS, the Yale Brown Obsessive Compulsive Scale. And then there's a 5-item severity scale that captures symptom severity impairment over the past month. So this is different from the Yale Brown Obsessive Compulsive Scale. And again, the severity looks at time occupied, distress, control, avoidance, and interference. Good internal consistency here, good convergent validity, because it has strong associations with self-reported obsessive compulsive symptoms, and the severity score is correlated with the severity score on the YBOCS. There has to be like another way to say that. I always want to say like Y box, but whatever. Um, It shows fair discriminant validity from anxiety and fair to poor discrimination from depression. So something to consider when using this assessment is that it might not discriminate from OCD from depressive symptoms. Also, there's been no evaluation of its test-retest reliability, and also there's no research-based recommendations for like a cutoff score. So a lot of times these self-report measures, like if they endorse so many items, that's a pretty good, like that cutoff score indicates that they most likely have OCD. But there's nothing really like that with this measure. Also, data on operating care. What? Oh yeah, that's the same thing I already just said. The cutoff scores, but also it does show good sensitivity in CBT studies. So, from what I've read, people who use this as a measure of treatment efficacy, it works pretty well. And then there is the Obsessive Compulsive Inventory Revised. This is an 18-item self-report measure. It assesses distress associated with obsessions and compulsions, good internal consistency here, and pretty good short-term test-retest reliability. It does show pretty good convergence with other scales, especially the YBOCS, but it has poor discriminant validity in terms of depression, anxiety, and worry. So I know that's kind of boring for me to kind of talk about, like the validity stuff and the reliability stuff, but it's really, when you are choosing your measures, it's stuff that we should be considering. Also, and there's, back to the OCIR, initial evidence supports the treatment sensitivity for the OCIR, but this needs to be replicated. It has pretty good potential use as like a screening measure, and in terms of like a cutoff for this, a total score of 21 on the scale, like a summed score, is sufficient for an OCD diagnosis. That's what like preliminary research suggests. So some things to consider when assessing for OCD is, again, using developmentally appropriate tools. As I mentioned, OCD in children is, I'm not going to say common because OCD in general is not common, but it's a thing. So you want to make sure you are using the right tools for the right individual. Also, reading level, which is something we talk about with every kind of assessment, including the MMPI-2 and like the PAI. You want to be sure, if you're administering a self-report measure, that the individual can read it and understand what it's asking. Functional impairment is also crucial in determining if a person meets the criteria for OCD, because if there's no functional impairment there, then they don't really, it's kind of a non-issue. I don't know how common that is, that somebody has like OCD and doesn't have functional impairment, but I digress. And it's also something you're going to consider in terms of their treatment. And then insight. Again, insight is important, especially because we have that specifier with OCD diagnosis, but also because limited insight is associated with a worse prognosis and kind of a different response to treatment. So if insight is limited and they don't recognize their obsessions as like worrisome and troubling, then they are not going to respond as well to therapy. And also family accommodation. So this was something I didn't really know about until I started looking into this stuff. So I didn't know that family members actually facilitate the completion of rituals, and they kind of assist in like avoidance behaviors. So that's kind of a super big problem, because if you're trying to treat somebody for OCD and their family members are essentially like enabling the completion of the rituals you're trying to prevent, you're going to want to know that because you're going to want to instruct the family to kind of just stop participating. And that goes back to the scale that I mentioned earlier, the family accommodation scale for obsessive compulsive disorder. So if you're if you're meeting somebody who you think has OCD, you might want to administer that just to see if family accommodation is a factor, because high levels of family accommodation kind of prevents patients from fully benefiting from the exposure response prevention therapy. So briefly, some cultural considerations. OCD occurs across all cultures, and it has a similar gender distribution, so more prominent in females than it is in men, or more common in females. However, culture can shape the content of obsessions. So like obsessions and compulsions may reflect common concerns within a culture. So, people in like a particular area or like a particular culture, we all have common concerns, right? And like we all are kind of worried about germs. We're all kind of worried about specific health problems, like Zika viruses or something like that. So I do have some like examples from studies. Compulsions related to possible contamination by asbestos was common in the UK like 2 to 3 decades ago, because that was like a big public concern. And then also in recent years, obsessions have like themes have revolved around HIV and AIDS, because that was like on the rise in like the 80s and 90s. Also, religion is a factor. Like as we talked about with like the behavioral model, like intrusive cognitions, like intrusive thoughts, that's fairly normal. But if you are like a highly religious person, you may attribute they'll attribute more significance to these thoughts, and that puts them at a greater risk of turning these thoughts into like clinical obsessions. Those with strict religious backgrounds tend to do that, like attribute more significance to these intrusive thoughts, so that might cause problems. So like blasphemous or sexual thoughts, that can cause a lot of distress, and this gets perpetuated through the like mechanisms that I was talking about earlier with the like the behavioral thing. Yeah. All right, what is next? Oh, treatment. So common treatment is exposure and ritual prevention. So this involves prolonged exposure to obsessional cues and then like the prevention of rituals. So exposure is done in vivo, which means like in real life. You ask the client to like, so if they have an obsession with like burning down the house, you ask them to like leave their stove on for an hour, and you're like exposing them to the threat, and then you have to encourage them to prevent engaging in the rituals. So it's kind of my understanding that like in the early days of this, oh gosh, I'm running out of time here. So in the early days of this, there was like a physical prevention of like the ritual behaviors, but now it's kind of just encouragement to not engage in it. As I mentioned already, SSRIs are a common treatment just because of that neurological etiology. So experts kind of advocate for the combined treatment with exposure and ritual prevention therapy and the SSRIs. But I was reading this book, and it was talking about how there's not a lot of conclusive findings regarding like how these two treatments compare and their combined efficacy. So are the two treatment approaches combined better than the other? So I was going to talk a little bit about OCD in popular culture, but I'm running out of time, so that's something we can chat about individually. And there's a little clip there, so if you would like to watch